is here to talk to us about transitioning from public to private funding. And before we get started, I just wanted to remind you all to please mute your audio if you haven't done so already, and to direct your attention to the messaging function of WebEx. We're going to be using that today to take questions. We will mostly be taking questions at the end, but if you have any pressing questions, please feel free to send them to me during the presentation, and I will pass them along to Nicholas. That being said, I will hand it over to Nicholas.
Thank you very much. I hope everybody's able to hear me okay, and I'm very happy to be with you today. And today we're going to be talking about the experience that I've had with Claire Foundation in going through the changes that were driven primarily by the recession of 2008 and the introduction of the Affordable Care Act. And it's titled "What It's Like to Be a CEO in the Transition from Public to Private Funding," and the parentheses is not by choice. Buddy Hackett had a quote that on his family's menu there was two choices: take it or leave it. And then there was another quote that also resonated with me, which is in these kinds of transitions, you either accept things the way they are, or you have to take the responsibility for changing them. You know, and choice I think is a very generous term. We saw public funding here at the Claire Foundation starting to disappear, and we had to do something to address that issue. Claire has been around the Claire Foundation has been around for about 45 years. We do drug and alcohol treatment on the west side of Los Angeles, primarily in Santa Monica, although our client base comes from a wide area in Southern California. We have traditionally been known as a service, treatment services to an indigent and homeless population. And for a long time, we were able to benefit from the funding that was coming down from some of the homeless funding dollars, and as well as substance use disorder dollars. And in the recession of 2008, those dollars began to disappear. So let me go to the agenda that we're going to be looking at today, just so everybody has an idea of what we're going to be talking about. So first, we're going to be taking a look at the early warning signs. And hopefully for anybody who's interested, these are some of the things that we had, and it may give you some ideas of some things that you'll be dealing with. Next, what options and opportunities were ahead of us, and what kinds of things we were looking at, and the kinds of signposts that we sort of used to guide us as we started looking at the possibilities. Next is the Affordable Care Act and its impact on Claire Foundation and the treatment services that we provide. Then was the big thing, what you don't know that you don't know. This turned out to be a huge area for us, and we'll spend some time talking about how we started to try to find out what we needed to do and what direction we were going in, and what kinds of things we had to look at. Generally, they were in the areas of the financial considerations, the organizational, board development, staffing, and technology, those areas we had to look at. Next was about getting into the race and the timing of that, and where we were going to position ourselves, and how that looked to us. And last is some reminders for you as you start looking at changing the direction of your organization. Hopefully not a lot of people will have to go through this, but if you do, there's some good reminders to keep in mind. And lastly, I'll take any questions that you have, and we'll try to do our best to answer those. So first is the early warning signs, and that looked like to us the homeless funding shifts from emergency shelters and transitional housing to Housing First model. This, for a long time, homeless funding included funding for substance use disorders, and a lot of studies have shown that 50% of the homeless persons living on the streets of our cities suffered from a substance use disorder or disability. We did a study here in Santa Monica with the Urban Institute, and they found 85%. Those of us who work in this field believe that that's probably well over 90% of the homeless, but that doesn't mean all of them need treatment. But generally, the homeless funding was fairly generous in terms of including substance use disorder treatment as part of their funding streams, and they encouraged the development and building of emergency shelters and transitional housing. For a long time, we were driven to that model, and then as the century turned and the decade of the 2000s came upon us, it began to, I think that the Malcolm Gladwell articles and writings on this subject that showing that hockey stick kind of funding for homeless people, that the incredible amount of dollars that are spent on them could be the philosophy and the approach changed to a housing first model. No matter what, put homeless people into housing and then start dealing with their issues. And that went against the continuum of care that included emergency shelters and transitional housing, which Claire had invested in. And as that model shifted, which we saw a lot of value in, the funding started to shift. And we are not a housing provider. We don't build permanent housing. Our sober living facilities, which we had about 100 beds, are often considered permanent housing, but they don't get funded under these permanent housing funding sources for homeless, nor under the supportive housing funding. So that money started to disappear from us. Next, we had to deal with the economic crisis of 2008. It put a very serious strain on public funding. And the majority of our funding came from block grants, from the federal block grant programs that flow into the state and into the counties, and we started to seeing reductions there. And it also started to impact public funding. Foundations saw their stock market, their portfolios sometimes reduced by 50%. They began to have to consider what they're giving and what kinds of money they could sustain. A few foundations were able to continue to give, but nowhere was it like what we had been used to leading up to it. And many of the foundations had many of the public. I'm sorry, this is still the public funding, but in the private funding, many of those private foundations had to start cutting their funds, and we suffered from that as well. On the horizon was the Affordable Care Act, and that looked like it was going to start driving us from a model where they would fund in social model public funding. They would fund a bed for anybody who qualified, and in the new model it looked like it was going to be insurance-based and a lot of private pay. But primarily the Affordable Care Act was going to drive those under 400% towards insurance, where that was probably not considered and not optional. It would become not only optional but required, or pay a penalty. And the system of being able to bill insurance companies and get reimbursements on a fee-for-service basis was not a language we spoke. We spoke public funding very, very well. We understood how to get that money, how to manage those grants, and make sure that we accessed all the funding that was available. We didn't speak insurance, and we did not know how to go after that, and that represented a real challenge for us. And these were the rumbles on the horizon, the kind of the clouds or the storms that were building, and it became a real considerable concern for us. As you can see here, I'll put up here on the right, in 2008, our revenue streams were about 60% government or public funded. Fundraising and fees were down around 32%. And in 2014, that has gone down to 46% of government funding. So just around the time of the recession, we could almost make our whole payroll with public funding. And now, even though we're bigger, government funding represents a smaller percentage of that and doesn't come close to covering anything like our current payroll. The good news is that we have beefed up our fundraising and our fees, which is where we're going to start charging people, and getting insurance and others are starting to become a little bit more robust. So in 2008 up here, that's what we were looking at, and what we anticipated was the kind of pie chart that you see down in 2014, and that's what we started to have to deal with. So options and opportunities. What were we going to do? How were we going to do it? What was the considerations that we wanted to bring on to the table? I'm fortunate. I have a terrific staff. One of the skills that I have is being able to hire people smarter than I am and keep them working with me. So I had a great staff to think this through with me. Our question was, and one of the principles that we put on the table was trying to sustain Clare and its 40, 50 years history of dealing with drug and alcohol treatment services and recovery services. We weren't trying to think about growth. At that time, we had a considerable amount of cash, and we realized going into recession that cash was going to be king. And we did have some credit lines available to us, and the board agreed that we would utilize the credit lines when necessary and not our cash, as we saw the recession continuing to drive people into real difficult cash positions. So growth was not one of the considerations, and we were just trying to sustain, not expand our services. Always with a nonprofit, you're mission-driven, you're not bottom-line driven, you're not profit-driven. So we had to answer to our mission, which is to provide effective and compassionate treatment and recovery and prevention services for alcoholism and substance abuse to individuals, families, and the community. So I'm going to show you that. This is our mission. And that is our guideline, and virtually is the checkpoint for any decisions that we make. And last, we had to look at what kind of capabilities we had, what we were known for, how did the community see us, and what did we have that could possibly be turned into a revenue-producing program, a revenue-producing service. So this was the kinds of things we thought about as we looked at what our options and opportunities were. So this is now, as the recession is settling in and we're starting to look at our future, starting to be driven by the Affordable Care Act. The Affordable Care Act was passed in the Senate on December 24th, 2009. Obama had just come into office. He had a Democratic Senate and a Democratic House, and I think that you remember that at the time the Senate passed this bill, it went over to the House in the next year, and a lot of amendments were being changed, and the Democrats forced the bill to be more of an amendment of the Senate, and was able to get it through on that. And it was signed into law by President Obama on March 23rd, 2010. So this is what's starting to drive our thinking. This is where we're starting to think the insurance clients are now going to have essentially vouchers in their pocket in the form of insurance benefits, and they're going to start looking for treatment. So we started to think about what this would be and where this might impact Clare clients. Maybe not necessarily what we have seen, but what a combination of our traditional clients and what we may see on the horizon. So In the Affordable Care Act, those clients that Claire traditionally saw, the indigent and the homeless, the Affordable Care Act, and California was one of those states that signed up for the Affordable Care Act in terms of the Medicaid funding. 138% of poverty in California were going to be now eligible for Medi-Cal. In California, Medicaid is called Medi-Cal. So 138% of poverty included many, if not all, of the clients that we had seen, except for the undocumented, which wouldn't be included that. Next, up to 400% of poverty would be available for some kind of credit, tax credit for signing up on the insurance coverage. Then we thought about others who might also have insurance and be interested in private pay, and we had to consider the treatment modalities, residential versus outpatient. Most insurance companies and the insurance treatment, insurance reimbursement in general is moving towards outpatient treatment. There's lots of studies to show that outpatient treatment works equally well as residential treatment. The outcomes are very similar. That has to be looked at in terms of the demographics. I don't think that the 138% of poverty do as well in outpatient as they would in residential, but those above that, I think, can do as well. So we started to think that we were going to have to strengthen our outpatient. Claire was primarily a residential treatment center. We had over 250 beds, including sober living, and we were going to have to start moving and start strengthening our outpatient. So these were the kinds of forces that were driving our decisions as we began to think about moving towards more of an outpatient service and what that would look like. So here was what frightened me. It's that slice of the pie that I think I know, that slice of the pie that I think I don't know, and that huge piece of the pie that I don't know. I had no idea of a lot of the things that might be facing me or what kinds of things I'd have to face. There were lots of people out there that had faced these issues, but Claire never had. We had been in a fairly insular world, a world where we had dealt with public funding. We had great relationships. We had a lot of integrity. We always delivered on our contracts and our promises. And now we were going to have to go into an insurance world, and insurance companies are not in the business to pay benefits. They're in the business of collecting premiums and not paying benefits. That was understood, and we just did not know all of the things that it was going to take to get us there. So the kinds of things that we thought about were, what were the financial considerations of trying to get into this business of attracting insurance clients and insurance clients with insurance? What were the financial impacts on the organization, and what were the financial impacts on sustaining revenue streams? We had no idea what kind of organizational talent we were going to have to develop. We did not have those kinds of people who understood benefits verifications, utilization reviews, et cetera, et cetera. So it was a big deal. Our board was made up primarily of people in recovery from the disease of alcoholism and drug addiction, and they had no idea about some of the more, the newer evidence-based practices. There was a time here at Claire when our board would only, back in the late 80s, early 90s, when only alcoholics were being treated at Claire. If you were a drug addict, you had to lie and say that you were an alcoholic. That changed, but that was the kind of stuff that our board dealt with over the years. Medication-assisted therapies in 12-step programs, those are often an anathema, and in our organization, we had never considered medication-assisted treatment, and now we're going to have to think about it. We're going to have to think about modalities that included harm reduction. In the old models, only abstinence was considered. So it took a lot for the board to bring their thinking around to what we were going to be doing. We think staffing and what we were going to have to add was going to be a big issue, and this was a consideration that that we had to take into analysis and study and decide where we were going to go with this. We knew it would take an investment in staffing ahead of the business model we were going after. We had pretty much agreed that we were going to try to do outpatient programming. That probably our outpatient programming was going to be done in 2 levels. One is the kind of public assistance level, the Medi-Cal, and whatever government funding was included, and we were going to call that one kind of treatment modality, and we were going to set up a mid-market aimed at more of a middle-income clientele that would be delivered outpatient services in a different setting. We had done some market research, and they were telling us clearly that Claire's reputation and Claire's history worked well, but that probably these 2 populations would not want to recover with each other. For example, a police employment assistance program would send their police into treatment at Claire. They would be happy to do that, but they couldn't necessarily recover with the same kinds of prison release and people that are sent here under court orders. So they needed a separate kind of facility. So that was driving us towards a mid-market. And the other big thing was technology. There was a big drive towards electronic health records. All insurance companies want information that they can get electronically, and we did not have that infrastructure. So these were the major areas that we felt fell into this what you don't know area, and we were going to have to take into considerations. So we started to bring in consultants, and in a lot of ways, consultants were our preferred technique, our preferred way of trying to deal with some of this information. It didn't add to staff and benefits costs. They're sometimes more expensive, but they're hired for a limited and a certain term, and they are able to provide expertise that you may not need ongoing in your organization. So I worked with an organizational consultant. I worked with an electronic health records consultant. We felt that Claire, which had been primarily a public assistance kind of an organization, one of the things we found in our surveys and market research was that Claire was often like dealing with the DMV, that if you got in line and we didn't like your attitude, there was always somebody next waiting because the beds were free, and we didn't have, it was an unfortunate aspect of public funding that we didn't really have to attract customers. We always had a line of people waiting to get in. So we realized that we were going to have to offer a call center and an admissions staff that became customer-oriented, customer-friendly, and respected the clients and really engaged and invited and wanted them, and didn't assume that the next person in line was going to be willing to pay the money to come in here. So we had an admissions consultant on top of that. So there was a lot of consultants we brought in. And then we decided, well, we should probably start getting in this race. You know, I always thought that, well, just as soon as I had my shoes on, I'd be ready to get in the race and get going, and the starting gun was off, and maybe I wasn't here at the lead of the pack. But then I realized this is what the pack looked like, and I had better get in here and find a place and start developing. You know, Claire was a very substantial organization, very financially set, but it really was late to the party, and in a lot of ways did not have everything it needed to get there, and we were playing catch up. We were someplace back there in the back of the pack. At one point, we decided to open our mid-market in one of the buildings we owned that was near our other facilities, and we then rethought that decision and decided to be separate, because much of what we were doing here related to the public assistance kind of clientele and population, and it would just be the assumption that our new treatment facility for outpatient mid-market would be the same as what we've always done. So we opened up a facility that was about 3 or 4 blocks away. We had a brand new build out. Unfortunately, had to commit to a 10-year lease, but you know, we thought we had the possibilities. And I will say that so far it's been encouraging. Everybody says we're ahead of the game. For an executive director, seeing the kinds of investment that it takes and the time it takes to start a new business, I become impatient at times, and I don't think that I can rush this. This is going to take a while to build a business. We now see a lot of people starting to follow our lead here on the west side of Los Angeles and getting into this outpatient treatment that we're trying to specialize in. I do think that we're doing the right thing. I do think it'll pay off, and as I said, you know, our reputation is helping us with that. So a couple of things to think about, a couple of reminders. Make sure you get plenty of help. Ask people who have done this. Bring on consultants. See what other people are doing and what's working for them and what might be working and the kinds of stuff that they're doing. Don't expect it to happen according to your plan. There will always be things that come up that are unexpected, and if you're not flexible, I think you're going to write a plan for failure. You need to be flexible, you need to be prepared for delays, and you have to be able in many ways to spend a lot more money than what you think. I think at one point that it's probably my deficit is about twice what I thought it was going to be, and you know, for some reason my board is putting up with it and still supports us. So if I don't get run out of town on a rail, I hope that I'm going to be successful. And just constantly reevaluate, constantly rethink. Don't be afraid to, just because, as I said before, just because you've got a plan and it's headed in a certain direction, don't be afraid to think that maybe you need to just make a slight left turn or a slight right turn and do things just a little bit differently as your circumstances change and as the marketplace changes. So I think that that's it for me. If anybody has any questions, I'll be glad to do the best I can to answer them, and I hope this was helpful to anybody who's in a similar position.
All right. Well, thank you so much, Nicholas. I have some really good questions for you. I will read them out. I think we have about 6 questions for you, so I'll read them and then let you give your thoughts, and then we can move on to the next one. So first of all, we have, what kind of consultants did you use to help rethink the business model to move away from government funding, and how did you find them?
Finding them it's interesting. I'll start at finding them is really often a matter of the kinds of people that I've met in in the nonprofit world. We're often involved in collaborations and partnerships and initiatives with other organizations, and there is about I would say anywhere from 30 to 50 different kinds of agencies around the west side of Los Angeles that have work that we touch with. And you run across consultants, you run across people, and they are often resources for these kinds of consultants. I think the consultants that I really relied on was somebody to do marketing research. We were very fortunate. We had a grant from an organization that helped us with our branding and identity, and one of the people on that, one of the professionals who came to help us with that, helped us with our marketing research. I really needed an organizational consultant, and a former planning officer from Deloitte Touche was in this business, and she's been with me for about 18 months, and she's currently working on our strategic plan and has proved to be invaluable in helping me think through the staffing and talent that I would need. I think I needed somebody who could help me think through the electronic health records and what we needed to do. We ended up spending a lot more money on this than we wanted to, but it was absolutely necessary, and probably without the consultant, I would have decided that based on money more than quality, and I got convinced to go for quality. So those were the primary consultants. During this time, we also had some development consultants helping us with our fundraising as we went through that. And I think that's it. And then we had somebody who was a very good friend of Claire's, who had been working in admissions for some of the big recovery centers here on the west side of Los Angeles, and he was very generously willing to come in and give us a reasonable rate to be a consultant on our admissions and call center. And we had to install a whole new phone system, and it was a big deal for us. But those were primarily the major consultants we worked with.
Great. So our next question is, does Claire Foundation utilize a lobbyist to monitor what is going on at the state/federal level? Are you working in coalition? How are you staying on top of what is going on?
Okay, that's a great question. Claire doesn't have a lobbyist. I'm a member of a group that does advocacy work at the state level and keeps us informed at the federal levels, and so that as that intersection applies to what we're doing here, county, state, and federal. This organization, it's called CADP, which is California Association of Alcohol and Drug Program Executives, if I have that right. They do advocacy work, and I work with them, and I try to stay on top of it. It's really a never-ending business. There's lots of stuff that goes on. There's NIMBY, not in my neighborhood groups that are always trying to pass city ordinances against some of the treatment facilities we have. There's a lot of stuff that goes on, and it's just something that you have to stay on top of and be part of. I found it easier to be part of groups rather than have a lobbyist.
Mm-hmm. Interesting. All right, so our next question is, will Claire utilize new residential treatment models for different levels of payers, such as middle class, now?
Yes. We anticipate that our residential treatment models will be public assistance with a more dormitory-style treatment model, and for a mid-market private insurance model, we'll probably go towards another facility that has, semi-private rooms, and it'll be a different model. Yes. Okay.
And do you need a different kind of board now? How are you going about finding a different board, if so?
We're working with consultants on board development. Our board has recently passed board terms, and in about 2-3 years, the first wave of people will be transitioning off. So we are currently working with consultants on developing a new board.
Great. And our last question is more of a statement. It sounds like you're seeing this as a 10-year change.
Yes, there's my impatience. I hope that we're going to be at break-even or turning a surplus on some of these programs that we're developing. We're really anticipating that our mid-market programs are going to afford to help support treatment for our traditional indigent homeless clientele, and we hope that that would take place within 2 to 3 years. I think in 10 years, I don't have patience for 10 years, so I'm hoping less than 5. I appreciate. That's what I keep hearing. I have to look at this in the very long term.
Well, it sounds like you're on the right track.
I appreciate that.
Well, I think that's about all that we have for today. But thank you, Nicholas, for joining us. It was great. I learned a lot. It was excellent. And thank you to everyone who is joining us, listening in. I hope you liked it and learned a lot as well. If you wanted to rewatch the presentation or missed any part of it, we will be putting it up on our website, and that's www.brimhallassociates.com. And also keep an eye out for our future e-newsletters. We have a lot of really great webinars coming up later in the year and next year, both on the CEO track, which is Nicholas's, and also the Fundraising 101 track. All right. Well, thanks for joining us. Happy Friday.
You know.